In 2024, scientists injected a gene therapy into mice that were the human equivalent of 80 years old. Frail, slow, dying, their remaining lifespan more than doubled. Their biological clocks reversed. Their bodies got younger. That same year, a dying man in a wheelchair received a kidney from a genetically edited pig. 6 months later, he threw the first pitch at Fenway Park. And in 2025, researchers combined 2 existing cancer drugs and extended the lives of laboratory mice by 35%. Right now, inside your body, 12 specific biological mechanisms are aging you, shortening your telomeres, poisoning your tissues with zombie cells, scrambling the software that tells your DNA what to do. For the first time in human history, scientists know exactly what those mechanisms are, and they are learning how to reverse them. The question is no longer whether aging can be stopped. The question is whether the science will arrive in time for you. Tonight, we are going to follow the evidence. From the Harvard labs rewriting the aging code, to the billionaires betting $10 billion that death is a solvable problem, from the pig organs keeping humans alive, to the AI systems compressing decades of drug discovery into months. And we are going to ask the question that no generation before us has ever had to face. Are we the last generation to die of old age? If you enjoy our calm nighttime journeys, remember to like and subscribe. We highly encourage our community to discuss the video topics in the comments and react to other comments. It is the most fun when we share our thoughts. Now, let us begin. Tonight we are going somewhere that might change the way you think about your own body. We are going to talk about a mouse that was the human equivalent of 80 years old, frail, slow, fading, and then scientists injected it with a gene therapy and its remaining lifespan more than doubled. We are going to talk about 2 drugs already approved for cancer treatment that, when combined, extended the lives of laboratory mice by 30%. We are going to talk about a dying man in a wheelchair who received a kidney from a genetically edited pig and 6 months later threw the first pitch at Fenway Park. We are going to talk about a single gene discovered in 2025 that can reverse the age of human cells without any of the dangers that have haunted this field for 2 decades. And we are going to talk about a concept so extraordinary that even the scientists studying it struggle to say it out loud. The possibility that you, listening to this right now, might be among the last human beings who ever have to die of old age. Chapter 1. The clock is already wrong. Right now, inside your body, something is happening that you cannot feel. It has been happening since the day you were born, and it has never stopped, not for a single second. Your cells are aging, not in some vague poetic sense, not as a metaphor for getting tired or slowing down. They are aging through specific, measurable, mechanical processes that scientists can now identify, name, and in some cases, reverse. Every time one of your cells divides, the protective caps at the ends of your chromosomes called telomeres get a little bit shorter. Think of them like the plastic tips on the ends of shoelaces. Every division wears them down. When they get too short, the cell can no longer divide safely. It enters a state called senescence. It stops working, but it does not die. It just sits there, leaking toxic inflammatory molecules into the surrounding tissue, poisoning its neighbors, accelerating the decline of everything around it. Scientists call these senescent cells zombie cells because they are not alive in any useful sense, but they refuse to die, and they accumulate. By the time you reach 60, your body is carrying a significant burden of these undead cells, silently corroding you from the inside. Meanwhile, your mitochondria, the tiny power plants inside each cell that convert nutrients into energy, are failing. Their membranes are weakening. Their output is dropping. The cellular machinery that once hummed with efficient precision is sputtering, leaking reactive oxygen species that damage DNA and proteins and lipid membranes in an accelerating cascade of dysfunction. You feel this as fatigue, as slower recovery after exercise, as brain fog that creeps in during the afternoon. But what you are really feeling is your mitochondria dying. And above all of this, governing all of it, your epigenome is drifting. Your DNA is the hardware. The epigenome is the software. It tells each cell which genes to turn on and which to keep silent. A liver cell and a brain cell contain identical DNA, but they function completely differently because the epigenome instructs them differently. As you age, that software degrades. Genes that should be off get turned on. Genes that should be active go silent. The instructions become garbled. The cell begins to forget what it is supposed to be. Harvard geneticist David Sinclair has described this as the information theory of aging. The idea that aging is not primarily caused by damage to your DNA, but by the loss of the epigenetic information that tells your DNA what to do. Your genes are still there. The music is still on the disc, but the reader can no longer find the right tracks. In 2023, a team of researchers, led by Carlos López-Otin, published a landmark update in the journal Cell. The original paper from 2013 had identified 9 hallmarks of aging, 9 distinct biological mechanisms that drive the deterioration of your body over time. The 2023 update expanded that list to 12: genomic instability, telomere attrition, epigenetic alterations, loss of proteostasis, disabled macroautophagy, deregulated nutrient sensing, mitochondrial dysfunction, cellular senescence, stem cell exhaustion, altered intercellular communication, chronic inflammation, and dysbiosis. 12 mechanisms, not one inevitable decline, not some mystical force called aging. 12 specific, identifiable, targetable biological processes, gears in a machine, gears that can be studied, gears that can be slowed, and according to a growing body of research, gears that can be repaired, replaced, or reversed. That last word is the one that changes everything: reversed. In 2024, a team at Rejuvenate Bio published a study in the journal Cellular Reprogramming that should have been front-page news around the world. They took mice that were 124 weeks old. In human terms, that is roughly equivalent to 77 years. These were not young mice. These were geriatric mice. Frail, slow, approaching the end. The researchers injected them with a gene therapy using 3 of the 4 Yamanaka factors, the transcription factors known as OCT4, SOX2, and KLF4. These are the molecules that can reprogram adult cells back toward a younger state. The therapy was delivered systemically through the bloodstream using a viral vector called adeno-associated virus 9, which distributes to tissues throughout the entire body. The mice received cyclic doses, 1 week on and 1 week off, for the rest of their lives. The results were staggering. The untreated control mice lived an average of about 9 more weeks after the injection point. The treated mice lived an average of 18.5 more weeks. That is a 109% extension of their median remaining lifespan. Their frailty scores improved. Their epigenetic clocks in heart and liver tissue reversed. When the same therapy was applied to human skin cells from a 65-year-old donor, those cells showed significant markers of epigenetic age reversal. The cells got younger, not metaphorically, measurably, quantifiably. By every biological clock researchers could apply, the cells reversed direction. Noah Davidson, the chief scientific officer at Rejuvenate Bio, said plainly that this is the first published work to actually have epigenetic reprogramming extend overall lifespan in normal mice. Not genetically modified mice, not specially bred laboratory strains, normal, wild-type mice, old ones, the kind that are supposed to die. And instead of dying on schedule, they got younger, and lived longer. Now let us be clear about what this means and what it does not mean. It does not mean we have cured aging. It does not mean you can walk into a clinic tomorrow and get an injection that will make you 20 years younger. The gap between mouse studies and human therapies is enormous, and it is littered with promising results that failed to translate. But what this study does mean is something profound. It means the biological clock inside your body is not a one-way mechanism. It can be run backward. The epigenetic drift that accumulates over decades of life can be reversed. The information that your cells have lost can be restored. The software can be rewritten. And that realization, that single scientific fact, changes the entire conversation about human mortality. Because if aging is not an irreversible decline but a reversible process, then the question is no longer whether we can do anything about it. The question is how fast the science is moving, and whether it is moving fast enough to reach you in time. There is a name for the exact moment when the science crosses that threshold, a name for the point when medical progress adds more than 1 year of healthy life for every year that passes. A name for the tipping point after which people who keep up with the latest treatments simply stop dying of old age. Not because they become immortal, but because the repairs keep arriving faster than the damage accumulates. That concept has a name, and it is closer than you think. Chapter 2: Longevity Escape Velocity. Imagine you are standing on a downward escalator. The escalator is aging. It pulls you steadily toward the bottom. Every year, it drags you a little further down. You can feel it in your joints, in your energy, in the way your body recovers a little slower from everything. That escalator has been running your entire life, and it has never stopped. Now imagine that medical science is a force pushing you upward. Every new treatment, every new drug, every new therapy gives you a small push against the descent. Right now, that push is modest. Current medical progress adds roughly 3 months of life expectancy for every year that passes. The escalator pulls you down 12 months. Science pushes you up 3. You are still descending, just a little slower than your grandparents did. But here is the question that keeps certain scientists awake at night. What happens when the push becomes stronger than the pull? What happens when science adds not 3 months per year but 6, then 9, then 12, then more than 12, is less than #0. 5 is greater than. The moment that ratio flips, the moment medical science adds more than 1 year of healthy life for every year you survive, you have reached what is called longevity escape velocity. And once you reach it, the math changes completely. Because every additional year you live gives the scientists another year to develop even better treatments, which give you another year, which gives them another year. The escalator is still pulling, but you are no longer descending, you are rising. And you keep rising, not because you have become immortal. You can still be hit by a bus. You can still get an aggressive cancer that outpaces the available treatments. You are not invulnerable, but you are no longer guaranteed to die of old age. The biological clock that was once your death sentence has become a problem that science solves faster than it progresses. The term longevity escape velocity was coined by the British biogerontologist Aubrey de Grey, who has spent more than 2 decades arguing that aging is an engineering problem with engineering solutions. De Grey is the founder of the LEV Foundation and one of the most polarizing figures in the longevity field. His critics call him a dreamer, his supporters call him a prophet, but his predictions have held remarkably steady over time. In 2024, De Grey stated that he believes there is more than a 50% chance that people who are currently 40 years old in the Western world will never die of aging-related causes. He predicts that humanity will reach longevity escape velocity sometime in the late 2030s. That timeline, he has noted, has not significantly shifted in over a decade. The science keeps advancing at roughly the rate he anticipated. His most famous provocation puts the stakes in the sharpest possible terms. The first person to live to 150, De Grey argues, is probably only about 10 years younger than the first person to live to 1,000. Because once you cross the threshold, once the treatments start arriving faster than the aging accumulates, the cascade is exponential. Each decade of extended life carries you into the next generation of breakthroughs. And each generation of breakthroughs extends your life further into the generation after that. Ray Kurzweil, the futurist and inventor who now works at Google, has made an even more aggressive prediction. Kurzweil believes longevity escape velocity will arrive by 2029 or 2030. He bases this on his broader analysis of exponential technological trends, and he has an 86% accuracy rate on his past predictions. George Church, the legendary geneticist at Harvard, and David Sinclair, whose lab produced the epigenetic age reversal results we discussed in the last chapter, have both pointed to the mid to late 2030s as the likely window. Peter Diamandis, the founder of the X Prize and the longevity optimization company Fountain Life, has put it bluntly: longevity is only about 7% heritable. The rest, roughly 70% or more, is in your control. Your job, Diamandis says, is not to die from something stupid in the interim. Give yourself the maximum chance to intercept these breakthroughs. You do not want to be the last person to miss it. Now, is any of this guaranteed? No, absolutely not. The history of medicine is full of breakthroughs in animal models that failed to work in humans. The gap between extending the life of a mouse and extending the life of a person is vast. And the most cautious voices in the longevity field, researchers like Matt Kaeberlein at the University of Washington and Brian Kennedy at the Buck Institute for Research on Aging, have pointed out that no intervention in animal models has yet exceeded the lifespan extension achievable through simple caloric restriction. We may be further from escape velocity than the optimists believe. But here is what is not speculation. Here is what is fact. In February 2025, the LEV Foundation completed its first major study in what it calls robust mouse rejuvenation. The last mouse in the study died on February 12th. Aubrey de Grey called the result a qualified win. The study combined multiple damage repair therapies simultaneously, targeting different hallmarks of aging at the same time. The results showed that the benefits were additive. Attacking multiple mechanisms of aging at once produced greater lifespan extension than any single intervention alone. This is the proof of concept for the entire strategy. Not one magic bullet, a combination, a cocktail of repairs that together push the body further back toward youth than any single treatment could manage, is less than #0, 5 is greater than. And in 2025, a landmark study published in Nature Aging demonstrated this principle with stunning clarity. Researchers at the Max Planck Institute for Biology of Aging combined two drugs: rapamycin, a compound originally discovered in soil from Easter Island that inhibits a master growth regulator called mTOR, and trametinib, a cancer drug that blocks a different arm of the same nutrient sensing network called the RAS-MEK-ERK pathway. Individually, rapamycin extended median lifespan in mice by about 17%. Trametinib alone extended it by about 5 to 10%. But together, the combination extended median lifespan by 35% in female mice and 27% in males. The effects were additive, not one drug doing the heavy lifting. Both drugs working together, targeting different gears in the aging machine, producing results that neither could achieve alone. The combination also reduced chronic inflammation across brain, kidney, spleen, and muscle tissue. It delayed tumor growth and reduced overall tumor burden. It blocked age-related increases in brain glucose uptake. The mice were not just living longer, they were living healthier. The treated mice at old age looked and functioned more like younger animals. Linda Partridge, the renowned geroscientist who co-led the study, was careful with her words. While we do not expect a similar extension to human lifespans as we found in mice, she said, we hope that the drugs we are investigating could help people stay healthy and disease-free for longer late in life. Both rapamycin and trametinib are already approved for human use. They exist. They are in pharmacies right now. The question is no longer whether these drugs can extend life in mammals. The question is whether the right doses, the right combinations, the right timing can translate their effects from mice to people. And that question is being answered right now in studies that are already underway. The pattern is becoming clear. Single interventions produce modest results. Combinations produce dramatic results. The future of anti-aging medicine is not one pill. It is a cocktail, updated annually, calibrated to your specific biology. A software update for your body, personalized by artificial intelligence to your unique epigenetic profile, your senescent cell burden, your biomarker panel. We are not there yet, but the road is shorter than most people realize. And the people racing down it are not waiting for academic consensus or government approval. They are pouring billions of dollars into companies, laboratories, and experiments designed to crack the aging code in the next 10 to 15 years. Some of them are the wealthiest people on Earth, and they are treating death the way they once treated the competition. As an engineering problem to be solved with enough money, enough data, and enough audacity, the longevity gold rush has begun, and the amounts of money involved will take your breath away. Chapter 3. The Billionaire Immortality Race. In 2022, a company called Altos Labs launched with $3 billion in funding. 3 billion. Not million. Billion. The money came primarily from Jeff Bezos, the founder of Amazon and one of the richest people in human history, and Yuri Milner, the Russian-Israeli tech billionaire. Their mission was straightforward if staggeringly ambitious. Reverse aging through cellular reprogramming. They hired Nobel laureate Shinya Yamanaka, the scientist who discovered the reprogramming factors we discussed earlier, as a senior advisor. They recruited top scientists from universities around the world, offering salaries that academia could not match. By late 2025, Altos Labs was rumored to be entering clinical trials, operating with a valuation that placed it among the most well-funded biotechnology companies on the planet. They are not alone. Retro Biosciences, backed by Sam Altman, the CEO of OpenAI, launched with $180 million. By 2025, the company had raised an additional $1 billion in new funding and was chasing a $5 billion valuation. Their internal pitch deck, according to reports, claims that longevity will be the greatest pharmaceutical market of all time, potentially surpassing the market value of companies like Eli Lilly and Novo Nordisk. Think about that for a moment. The companies that make insulin and Ozempic and the weight loss drugs that have reshaped the pharmaceutical landscape, Retro Biosciences, believes that aging itself is a bigger market than all of them, and they may be right. Because every human being on Earth ages. Every single one. There is no larger addressable market in the history of commerce. Then there is Calico Labs, founded by Google co-founder Larry Page in 2013. Calico has operated in near total secrecy for over a decade, absorbing enormous funding with very little public output. They partnered with pharmaceutical giant AbbVie, but that collaboration ended in 2025 after 5 unsuccessful clinical trials. Whatever Calico is doing behind closed doors, it has not yet produced the breakthrough its founders envisioned. But the investment continues. The patience of billionaires with immortality on the line is apparently infinite. The global anti-aging market as a whole hit $85 billion in 2025 and is projected to reach $120 billion by 2030. Longevity clinics now operate in the United States, Switzerland, the United Arab Emirates, and a growing number of other countries. They offer whole genome sequencing, epigenetic age testing, VO2 max analysis, DEXA body composition scans, and experimental therapies for tens of thousands of dollars per year. This is no longer fringe science. This is an industry. And it is racing ahead of regulation at a pace that makes some researchers very nervous. But no one embodies the extremes of the longevity movement quite like Brian Johnson. Johnson is a tech millionaire who sold his payments company Braintree to eBay for $800 million and then turned himself into the most documented human experiment in history. His program is called Blueprint, and it involves spending over $2 million per year on a regimen so strict that it essentially removes human decision-making from his daily life. Over 100 daily supplements, a precisely measured caloric intake, hour-long daily workouts, bedtime at 8:30 every single night, red light therapy, blood plasma analysis, continuous monitoring of over 70 organ systems. Johnson claims extraordinary results. His most cited metric in 2025 was a rate of aging of 0.50, meaning his body supposedly ages only 6 months for every 12 months that pass. His biological skin age reportedly reversed from 64 to 36. He has made himself the public face of aggressive self-optimization, documenting everything on social media and inviting the world to watch a man try to outrun his own mortality in real time. But the scrutiny has been fierce. Morgan Levine, the Yale researcher who pioneered some of the epigenetic clock tools Johnson cites, has publicly challenged his methodology. Levine has pointed out that epigenetic clocks measure a snapshot in time and cannot substantiate claims of 31 years of aging reversal from a single measurement. The tools were designed for population-level research, not for individual before and after claims. Johnson is measuring himself with instruments that were not built for the purpose he is using them for. Other researchers have been less diplomatic, noting that self-reported results from a single subject with no control group and no peer review do not constitute science, they constitute marketing. And yet Johnson has done something that no academic paper could have accomplished. He has made the conversation about aging reversal mainstream. Millions of people who would never read a journal article about senolytics or epigenetic reprogramming have encountered these concepts through his social media presence. He is a walking advertisement for the idea that aging is something you can fight. Whether his specific results are real or exaggerated, the cultural impact is undeniable. The longevity industrial complex, as some researchers have begun calling it, raises profound questions that go beyond the science. Marco De Maria, the editor-in-chief of the journal Aging, wrote an editorial in 2025 warning that the explosion of longevity clinics risks reinforcing inequality and weakening the credibility of the science behind aging research. When wealthy people pay tens of thousands of dollars for unproven treatments at glossy clinics, it blurs the line between evidence-based medicine and luxury wellness. And when the results are self-reported and the providers are financially incentivized to tell clients what they want to hear, the potential for harm is significant. The American Medical Association devoted an entire issue of its Journal of Ethics in December 2025 to the question. The title was provocative: "Aging is bad for you." The issue examined whether the rush to treat aging as a disease could undermine civic virtue, deepen inequality, and distort medical priorities. The authors asked uncomfortable questions. Who benefits when aging becomes a market? Who is left behind? And what happens to a society where the wealthiest citizens live decades longer than everyone else, is less than #0, 5# is greater than? These questions will become more urgent as the science advances. Because the science is advancing fast. The billions being poured into Altos Labs and Retro Biosciences and Calico and dozens of smaller companies are not vanity projects. They are funding real research by real scientists, pursuing real biological mechanisms. The money is accelerating the timeline, and the timeline was already accelerating on its own. The most powerful tool in the longevity arsenal right now is not a drug or a supplement or a billion-dollar lab. It is a biological mechanism discovered in 2006 by a Japanese scientist who was trying to understand how cells remember what they are. A mechanism so powerful that it can literally rewind a cell to an earlier version of itself, erase decades of accumulated damage, restore youthful function to tissues that had lost it. It is called cellular reprogramming. And when you understand how it works, you will understand why some of the smartest people on Earth believe we are on the verge of the most radical transformation in the history of medicine. Chapter 4. The Yamanaka Reset. In 2006, a scientist at Kyoto University named Shinya Yamanaka published a paper that would earn him the Nobel Prize and permanently alter the trajectory of biology. What Yamanaka discovered was deceptively simple. He identified 4 transcription factors, 4 proteins that when introduced into an adult cell could reprogram it all the way back to a pluripotent stem cell state, a state of total youth, a state in which the cell had forgotten everything it had become and returned to the beginning, ready to become anything again. The 4 factors are OCT4, SOX2, KLF4, and C-MYC. Together, they are known as OSKM, or the Yamanaka factors. When you expose an adult skin cell, a liver cell, a blood cell to these 4 molecules, something extraordinary happens. The epigenetic clock resets. The accumulated chemical marks on the DNA that told the cell its age, its history, its accumulated damage, they get erased. Telomeres lengthen. Mitochondrial function restores. Gene expression patterns shift back to those of a young cell. By every measurable standard, the cell becomes young again. This was a revolution. Before Yamanaka, the assumption in biology was that cellular aging was a one-way street. Cells could go forward, they could not go back. Differentiation, the process by which a stem cell becomes a specialized cell type, was considered irreversible. Once a skin cell, always a skin cell. Once old, always old. Yamanaka shattered that assumption. He proved that the information needed to make a cell young again was still stored inside it. The DNA had not changed. The genetic code was intact. What had changed was the epigenetic layer, the regulatory instructions on top of the code, and those instructions, it turned out, could be rewritten. But there was a problem. A serious one. If you fully reprogram an adult cell, if you turn on the Yamanaka factors and let them run without stopping, the cell loses its identity entirely. It does not just get younger, it becomes a pluripotent stem cell. And pluripotent stem cells, while extraordinarily powerful, are also extraordinarily dangerous in the wrong context. They can form tumors called teratomas, disordered masses of tissue that grow uncontrollably. Full reprogramming in a living organism is essentially giving cells permission to become anything, including cancer. So the field pivoted. The question became not whether you could reprogram cells, but whether you could do it partially. Could you wind the clock back just far enough to rejuvenate the cell without erasing its identity? Could you make a liver cell younger while keeping it a liver cell? Could you find the sweet spot between youth and chaos? The answer, it turned out, was yes. Researchers discovered that brief, cyclic exposure to the Yamanaka factors, or to a subset of them, could rejuvenate cells without pushing them over the edge into pluripotency. The trick was timing. Short pulses of reprogramming followed by rest periods, a week on, a week off, enough to nudge the epigenetic clock backward, not enough to erase the cell entirely. In 2020, David Sinclair and his team at Harvard demonstrated this with breathtaking elegance. They used 3 of the 4 Yamanaka factors, OCT4, SOX2, and KLF4, without C-MYC, which is the factor most strongly associated with tumor formation. They delivered these 3 factors into the retinal ganglion cells of mice that had lost their vision due to age-related damage, and the mice could see again. The optic nerve fibers, which in adult mammals were thought to be incapable of regeneration, regrew. The epigenetic age of the treated cells reversed. Vision was restored in blind mice, using gene therapy to turn back the clock inside their eye cells. Sinclair described the work as setting out to answer a fundamental question. Can you reset the epigenome? Can you reverse the clock? The answer was unequivocal. Yes, you can. The lifespan study we discussed in Chapter 1, the 109% extension in geriatric mice published in 2024, used this same approach. Systemic delivery of OSK factors via adeno-associated virus, cyclic induction, and the results were not limited to a single organ. The frailty of the entire animal improved. The epigenetic age of heart and liver tissue reversed. The therapy did not just fix one problem. It appeared to roll back the biological clock across multiple tissues simultaneously. Now the race is on to bring this to humans. Life Biosciences, a company founded to commercialize the work emerging from Sinclair and related labs, has developed a program called ER100 targeting optic neuropathies. Conditions like glaucoma, a non-arteritic anterior ischemic optic neuropathy that cause vision loss through damage to the optic nerve. Their approach uses the same OSK framework delivered via gene therapy directly to the eye. In the first quarter of 2026, Life Biosciences received IND clearance from the FDA to begin human clinical trials. If this works, if partial reprogramming can restore vision in human patients the way it did in mice, it will be the first concrete proof that epigenetic age reversal translates from laboratory animals to living human beings. The implications would ripple through every branch of medicine. But the Yamanaka factors, even the partial cocktail of OSK, still carry concerns. They are transcription factors associated with the machinery of pluripotency. Even without c-Myc, there is a residual risk that cells could be pushed too far. The field has been searching for a way to achieve the same rejuvenation without any of the pluripotency risk. And, in June of 2025, they may have found it. A Cambridge-based biotech company called Shift Bioscience published a preprint describing something no one had demonstrated before. A single gene, designated SB000 to protect its identity before full publication, that can reverse the biological age of human cells from multiple tissue types, with potency rivaling the Yamanaka factors. But unlike the Yamanaka factors, SB000 does not activate pluripotency pathways. The cells rejuvenate, but they remain what they are. A skin cell stays a skin cell. A lung cell stays a lung cell. They just become younger versions of themselves. 2 weeks of SB000 expression reversed transcriptomic age in aged human fibroblasts by an average of 4.5 years. 6 weeks restored youthful DNA methylation patterns. Steve Horvath, one of the leading aging clock researchers in the world, highlighted the preprint as a potential breakthrough. The work has not yet been peer-reviewed, and the identity of the gene has not been publicly disclosed. Skepticism is warranted. But if the results hold, SB000 could solve the safety problem that has haunted cellular reprogramming since Yamanaka first discovered it 2 decades ago. A single gene, no tumor risk, rejuvenation across multiple tissue types, a younger cell that still knows exactly what it is. This is the frontier, and it is moving faster than most people realize. Reprogramming can make old cells young, but what about the cells that are already too far gone? The zombie cells that have stopped dividing and started poisoning everything around them. You cannot reprogram those. They are beyond repair. You have to kill them. Chapter 5. Killing the zombie cells. There is a cell inside your body right now that has given up. It stopped dividing a long time ago. It received too much damage, too many signals that something was wrong, and it activated an internal emergency brake called cellular senescence. In a young body, this is actually a good thing. Senescence is a cancer prevention mechanism. When a cell becomes damaged in a way that could lead to uncontrolled growth, the senescence program shuts it down. The cell stops replicating. In a healthy young body, the immune system swoops in, clears the senescent cell away, and fresh new cells replace it. The system works beautifully. But as you age, two things go wrong at the same time. The number of cells entering senescence increases because there is more damage accumulating, and the immune system, which is itself aging, becomes less efficient at clearing those cells out. The result is accumulation, more and more zombie cells piling up in your tissues, year after year, decade after decade. And here is the thing about zombie cells. They do not just sit there quietly. They secrete a cocktail of inflammatory molecules that scientists call the senescence-associated secretory phenotype, or SASP. This toxic brew includes cytokines, chemokines, growth factors, and proteases that damage the surrounding healthy tissue, drive chronic inflammation, accelerate every other hallmark of aging, and even push neighboring healthy cells into senescence. It is biological sabotage. The zombie cells are not just dead weight. They are actively making everything worse. If you could find a way to selectively destroy these cells, to clear them out of the body the way the young immune system once did, you would remove one of the most significant drivers of age-related decline. That is the idea behind senolytics. Drugs designed to seek and destroy senescent cells while leaving healthy cells intact. The story of senolytics begins with a researcher named James Kirkland at the Mayo Clinic in Rochester, Minnesota. Kirkland and his team pioneered the concept of pharmacologically eliminating senescent cells and identified one of the first senolytic combinations. The drug dasatinib, originally developed as a cancer treatment, combined with quercetin, a flavonoid found naturally in foods like onions and apples. Together, this combination, known as DQ, was shown to selectively kill senescent cells in animal models while sparing normal cells. Mice treated with DQ showed improved physical function, reduced inflammation, and extended health span. Since then, senolytics have moved from animal models into human clinical trials with remarkable speed. In 2025, the Stamina trial tested dasatinib plus quercetin in older adults with slow gait speed and mild cognitive impairment, two hallmarks of biological aging that predict decline and dependency. A Phase 2 randomized controlled trial tested the same combination in postmenopausal women and found that bone formation markers increased by 16% overall. More importantly, the benefit was strongest in the women who had the highest senescent cell burden, as measured by a biomarker called P16. This is a critical insight. Not everyone accumulates senescent cells at the same rate. Some people have a much higher burden than others, and the data from this trial suggests that senolytics work best in the people who need them most. It points toward personalized senolytic therapy, where your treatment is calibrated to your specific level of cellular damage, rather than applied as a one-size-fits-all approach. Sandeep Khosla, a researcher at the Mayo Clinic who helped design this analysis, has argued that this personalized approach is the future of the field. Measure the burden, target the treatment, clear the damage that is actually there. The applications are extending beyond aging itself. A 2025 Phase 2 trial combined senolytics with anti-PD, one immunotherapy in patients with head and neck cancer, and achieved a 33.3% major pathological response rate. Senescent cells, it turns out, create a microenvironment that helps tumors evade the immune system. Clear the zombie cells, and the immune system can do its job against the cancer. Senolytics as cancer therapy is an entire emerging field. But dasatinib and quercetin are what scientists call first-generation senolytics. They work, but they are blunt instruments. They do not kill every senescent cell, and they have side effects at higher doses because their selectivity is imperfect. The next wave of senolytic therapies aims to be far more precise. One approach uses CAR T cells, the same engineered immune cells that have revolutionized blood cancer treatment. reprogrammed to hunt and destroy senescent cells. In cancer therapy, CAR T cells are engineered to recognize a specific protein on the surface of tumor cells. The same technology can theoretically be applied to senescent cells if a surface marker unique to senescence can be identified. Multiple research groups are working on exactly this. The challenge is finding a target that is present on senescent cells but absent from healthy ones. Get that right, and you have a precision-guided missile for zombie cells. Another approach is even more ambitious: senescent cell vaccines. The idea is to train the immune system to recognize and destroy senescent cells on its own, the way vaccines train the immune system to fight viruses. If successful, a senescence vaccine would not require repeated drug treatments. A single vaccination could potentially enable the body to clear its own zombie cells automatically, restoring the process that worked in youth but broke down with age. A third approach uses antibody-drug conjugates, antibodies that seek out senescent cell markers and deliver toxic payloads directly to the target. This borrows from the same strategy used in modern cancer drugs and could offer the precision of CAR T therapy without the complexity and cost of engineering personalized immune cells. The race to develop second and third generation senolytics is one of the most consequential in all of medicine, because senescent cells are not just a hallmark of aging, they are a driver of aging. They are a cause, not merely a symptom. Remove them, and you do not just slow the decline, you remove a force that was actively accelerating it. Senolytics clear the damage that has already accumulated. Reprogramming reverses the aging of cells that are still functioning. But there is a third front in this war against aging that involves something no one expected to work. Something that sounds like science fiction but is happening right now in hospitals in Boston and New York, and will soon be happening in formal clinical trials approved by the FDA. It involves transplanting organs from a completely different species into human patients. And the story of how it went from impossible dream to medical reality begins with a 66-year-old man in New Hampshire who had run out of options in a pig with 69 genetic edits. Chapter 6: Organs on Demand. Tim Andrews was 66 years old and dying. He had been on dialysis for more than 2 years. End-stage kidney disease had stolen his energy, his independence, and most of his hope. He was non-ambulatory, confined to a wheelchair, and his life had contracted to the rhythms of a dialysis machine. The fishing trips were over, the walks with his dog Cupcake were over, the visits to Fenway Park to watch the Red Sox, the thing that had brought him joy since he was a boy, those were over too. He was fading and he knew it. Andrews had O-type blood, which meant his wait for a human kidney donor was especially long. Most patients wait 3 to 5 years. Patients with O blood type wait 5 to 10. Given his age and declining health, his doctors estimated he had only a 9% chance of receiving a human kidney within the next 5 years. His probability of being removed from the transplant waitlist due to illness or death within that same period was 49%. Nearly a 1 in 2 chance that he would die waiting for an organ that might never come. On January 25, 2025, surgeons at Massachusetts General Hospital in Boston offered Tim Andrews a different kind of kidney, one that did not come from a human donor. It came from a pig. The kidney was produced by a Cambridge, Massachusetts biotech company called eGenesis. Using CRISPR-Cas, 9 gene editing technology, scientists had made 69 modifications to the pig genome. 3 edits removed pig-specific sugar molecules on the cell surfaces that would trigger immediate rejection by the human immune system. 7 edits added human genes to reduce inflammation, prevent blood clotting, and improve compatibility. And 59 additional edits inactivated porcine, endogenous retroviruses, ancient viral sequences embedded in the pig genome that could theoretically be reactivated and harm a human recipient. The surgery was performed under the FDA Expanded Access Pathway, commonly known as compassionate use, a program that allows patients with no other options to access experimental treatments. Andrews was the fourth person in the world to receive a genetically edited pig kidney, and the second patient in eGenesis and Massachusetts General Hospital's multi-patient study. The kidney functioned immediately. Andrews woke up from surgery and described the moment as feeling like the cloud of dialysis had disappeared. He said he felt re-energized and revitalized. He called it a miracle. His creatinine levels dropped. He stopped dialysis for the first time in over 2 years. He was discharged from the hospital about a week after the procedure. He went home to New Hampshire. He started cooking again. He started vacuuming again. He took long walks with Cupcake. And on June 16, 2025, 137 days after receiving a pig kidney, Tim Andrews stood on the pitching mound at Fenway Park and threw the first pitch at a Boston Red Sox game. His wife Karen was there, his family was there, members of his medical team were there. A man who 6 months earlier had been dying in a wheelchair was standing under the lights, throwing a baseball. Andrews became the longest surviving human recipient of a pig kidney, surpassing all previous records. His kidney functioned for 271 days before declining function led to its removal in October 2025. He returned to dialysis and went back on the transplant waitlist for a human kidney. The kidney itself, when examined after removal, showed no signs of acute rejection. The failure appeared to be related to chronic processes that researchers are still studying. But the larger significance of Andrews' journey is enormous. He proved that a genetically edited pig kidney can function in a living human body for months. It can maintain water balance, mineral balance, and waste filtration in a manner very close to a human kidney. It can give a dying person their life back. He is not the only one. Bill Stewart, another patient who received a pig kidney xenotransplant, completed a 2-hour bike ride just weeks after his surgery. The lives of real people are being transformed by organs grown inside animals that were genetically engineered to be compatible with human biology. The need is staggering. More than 100,000 people in the United States are on the waiting list for an organ transplant. 17 people die every single day waiting for an organ that never comes. For kidney disease specifically, more than 800,000 Americans live with end-stage kidney disease. Only about 28,000 kidney transplants were performed in 2024. The rest survive on dialysis, a treatment that has a 5-year mortality rate exceeding 50%, higher than that of the most common cancers. In September 2025, the FDA approved an investigational new drug application for eGenesis's eGen 2784 kidney, clearing the way for a formal phase 1-2-3 clinical trial. United Therapeutics, another company working with genetically edited pig organs, received separate IND clearance for its own pig kidney trial called Expand. The era of experimental compassionate use is transitioning into the era of systematic clinical testing. And pig kidneys are just the beginning. In 2022, surgeons at the University of Maryland transplanted a genetically edited pig heart into David Bennett, a 57-year-old man who had no other options. Bennett survived for 2 months. The heart functioned. The lessons learned from his case about immune profiling, viral screening, and immunosuppression protocols are informing every xenotransplant that follows. Pig livers are in early-stage exploration, and beyond xenotransplantation entirely, 3-dimensional bioprinting of human organs using specialized printers that deposit layers of living cells is advancing. Full organ bioprinting remains years away, but the convergence of gene editing, xenotransplantation, and bioprinting points toward a future in which organ failure is a solved problem. A future in which no one dies waiting for a kidney, or a heart, or a liver, because the organs can be grown, engineered, and delivered on demand. We can grow organs in pigs. We can reprogram cells to become younger. We can kill the zombie cells poisoning our tissues. But all of these interventions share one problem. They take time. Time to discover. Time to test. Time to refine. Time to approve. What if we could compress that timeline from decades to months? There is a technology that might be able to do exactly that, and it is the same technology that is rewriting every other industry on Earth. Chapter 7: The AI Accelerator. For most of the history of modern medicine, developing a new drug has followed the same brutal timeline. Identify a target, screen thousands of candidate molecules, run years of preclinical testing, enter human clinical trials, navigate regulatory approval. From initial concept to an approved drug reaching a patient, the average timeline is 12.5 years. The average cost exceeds $2 billion, and the failure rate is catastrophic. More than 90% of drug candidates that enter clinical trials never make it to approval. This timeline has been the bottleneck for every field of medicine, and aging research is no exception. You can identify a promising target. You can demonstrate results in mice. But translating that into a safe and effective human therapy takes over a decade, even when everything goes well. For a field where the patients are literally dying of the passage of time, that bottleneck is not just frustrating, it is lethal. And then artificial intelligence entered the laboratory. In 2020, a company called DeepMind, a subsidiary of Google, released AlphaFold. It was a system that could predict the three-dimensional structure of proteins from their amino acid sequences with near experimental accuracy. This might sound abstract, but it is difficult to overstate its significance. Proteins are the molecular machines that carry out nearly every function in your body. Their three-dimensional shape determines what they do, and knowing that shape is the essential first step in designing a drug to interact with them. Before AlphaFold, determining the structure of a single protein could take years of painstaking laboratory work using X-ray crystallography or cryo-electron microscopy. AlphaFold predicted the structures of over 200 million proteins, essentially every known protein in every studied organism. In one stroke, it solved a problem that had consumed decades of experimental work and billions of dollars. AlphaFold 3, released in 2024, expanded beyond proteins to model interactions between proteins and DNA, proteins and RNA, and proteins and small molecule drugs. It did not just predict what proteins look like, it predicted how they interact with everything else. This created an entirely new substrate for drug discovery. Instead of blindly screening millions of compounds hoping one fits a target, researchers could now computationally model the interaction and design molecules that fit with precision. Isomorphic Labs, a spin-off of DeepMind focused on drug discovery, secured over $600 million in funding to build drugs using AlphaFold integrated design. Demis Hassabis, the co-founder of DeepMind and now the head of Isomorphic Labs, has said that he believes there is no more important application for artificial intelligence than helping to improve human health. The impact is already being felt. In Silico Medicine, a company that uses AI across the entire drug development pipeline, brought a fibrosis drug candidate called ISM 001055 from initial concept to human clinical trials in under 18 months. The traditional timeline for that journey is over a decade. 2025 saw the highest single-year jump in investigational new drug filings for AI-originated molecules, a clear signal that the pharmaceutical industry is no longer experimenting with AI. It is depending on it. The market reflects this transformation. AI in pharmaceuticals is projected to grow from $1.8 billion in 2023 to over $13 billion by 2030. And the technology is not limited to proprietary corporate systems. Open source models like OpenFold 3 and Boltz 2 are democratizing access, allowing academic labs and smaller companies to use the same structural biology tools that were once the exclusive domain of billion-dollar corporations. But the most exciting convergence is happening at the intersection of AI and longevity research specifically. Retro Biosciences, the Sam Altman-backed company, chasing a $5 billion valuation, partnered with OpenAI to build biology-focused AI models. Their collaboration has already produced results. They used AI to engineer stem cell proteins with efficiency improvements of up to 50-fold, meaning they can produce key biological tools 50 times more effectively than previous methods. That kind of efficiency gain does not just speed up research, it fundamentally changes what is economically feasible. Gero, a longevity company founded by a theoretical physicist named Peter Fedichev, is applying AI in a different way. Fedichev approaches biological aging the way a physicist approaches a complex system, using mathematical models to describe the dynamics of deterioration and identify intervention points. Gero signed a deal with Japanese pharmaceutical giant Chugai worth up to $250 million to develop aging-related therapeutics using their AI platform. Deep learning is being used to build increasingly sophisticated aging clocks, computational models that can estimate biological age from blood samples, DNA methylation patterns, or even photographs. These clocks are not just diagnostic tools. They are becoming the primary readout for clinical trials. If you want to test whether a drug reverses aging, you need a way to measure biological age before and after treatment. AI-built clocks are that measurement tool. AI is also being used to identify geroprotectors, compounds that slow aging, from existing drug libraries. By analyzing the molecular signatures of known aging interventions and comparing them against databases of approved and experimental drugs, AI systems can flag unexpected candidates. This is how drugs like rapamycin and metformin were first connected to aging research, through patterns that human researchers did not see, but computational systems could detect. Perhaps most ambitiously, AI is being used to generate dual-purpose therapeutics, drugs that simultaneously target aging mechanisms and specific diseases. A drug that reduces senescent cell burden and treats a particular cancer. A drug that improves mitochondrial function and addresses a specific form of neurodegeneration. The old model of one drug for one disease is giving way to a new model, where drugs are designed to address the underlying biology of aging, while also treating its downstream consequences. The timeline is compressing. What once took 12 years is beginning to take 18 months. What once cost $2 billion is beginning to cost a fraction of that. And the targets being pursued are no longer limited to individual diseases. They are aimed at aging itself. AI is compressing the timeline. Billions are being spent. The science is working in mice. But there is one woman who did not wait for the science to finish. In 2015, she flew to Colombia and injected herself with an experimental gene therapy that had only been tested in rodents. She claims it reversed her aging by 20 years. Her name is Elizabeth Parrish, and her story raises the most uncomfortable question in the entire longevity field. When the stakes are this high and the clock is ticking, how far are people willing to go? Chapter 8. Patient Zero. In September of 2015, Elizabeth Parrish, the CEO of a small biotechnology company called BioViva, boarded a plane and flew to Colombia. She was 44 years old. She was not sick. She was not dying. She was not enrolled in any clinical trial. She was going to inject herself with 2 experimental gene therapies that had never been tested in a human being. The first therapy was designed to induce the production of telomerase, the enzyme that lengthens telomeres, the protective caps on the ends of chromosomes that shorten with every cell division. The theory was straightforward. If telomere shortening is a driver of aging, then lengthening telomeres should reverse or slow that process. The second therapy delivered a gene called follistatin, which promotes muscle growth and counteracts the muscle wasting that accompanies aging. Parrish received the injections in a clinic outside of United States jurisdiction. She did this deliberately. The therapies had not been approved by the FDA. They had not completed the standard preclinical safety testing required for human trials. They had shown promise in rodent models, but the gap between mice and humans is enormous and filled with unknowns. What Parrish did was, by any conventional standard, extraordinarily risky. 6 months later, she released results, claiming that her white blood cell telomeres had lengthened from 6.71 kilobases to 7.33 kilobases. That represented an increase equivalent to roughly 20 years of telomere reversal. She was 44 when she received the treatment. She has since claimed a biological age of 25 at a chronological age of 53, based on ongoing testing. The scientific community responded with a mixture of fascination and alarm. Critics pointed out serious methodological problems. Telomere measurements in white blood cells have a variability of roughly 10%, meaning the observed change could fall within normal measurement error. White blood cells do not represent the whole body. Telomere length in one tissue does not necessarily reflect telomere length in others. The results were uncontrolled, meaning there was no comparison group to rule out natural variation, and the findings were never submitted for peer review. Duncan Baird, a telomere researcher at Cardiff University, was blunt. "Meddling with a fundamentally important tumor-suppressive mechanism," he said, "does not strike me as a particularly good idea. Telomere shortening is not just a bug, it is a feature. It is one of the body's primary defenses against cancer. When a cell accumulates too much damage, short telomeres prevent it from continuing to divide. Artificially lengthening telomeres could remove that safety brake, potentially allowing damaged cells to proliferate, unchecked." Parrish has continued undeterred. She has reportedly undergone additional gene therapies targeting cognition and metabolism. BioViva operates outside US jurisdiction, offering experimental treatments from locations in the Bahamas and Colombia. The cost of telomerase gene therapy through their network reportedly ranges from $2.5 to $3.5 million per dose. Parrish is not alone in operating outside the boundaries of conventional medicine. A small but growing underground of wealthy individuals is accessing experimental gene therapies, stem cell treatments, and senolytic protocols through offshore clinics in countries with more permissive regulatory frameworks. The United Arab Emirates, the Bahamas, Colombia, parts of Southeast Asia. These are not back-alley operations. They are sleek, well-funded clinics staffed by trained physicians, offering treatments that are technically legal in their jurisdictions but would be prohibited in the United States or European Union. This is creating a two-tier system that should trouble anyone who thinks about the future of medicine. On one track, regulated science moves methodically through preclinical studies, clinical trials, and regulatory review. It is slow, it is careful, and it is designed to protect people from harm. On the other track, unregulated experimentation moves as fast as the client's willingness to pay and the provider's willingness to inject. It is fast, it is bold, and it is accountable to no one except the person writing the check. The tension between these two tracks is real, and it is growing. Every year that regulated science takes to complete a trial is a year that wealthy early adopters can access the same or similar treatments through back channels. The incentive structure is clear. If you believe that longevity escape velocity is approaching, and that every year of additional life increases your chance of reaching it, then waiting for FDA approval starts to feel like a death sentence delivered in slow motion. On the opposite end of the spectrum from Parrish and the offshore clinics sits one of the most rigorous and carefully designed studies in the history of aging research, the Dog Aging Project. Launched in 2019, the Dog Aging Project has enrolled over 50,000 companion dogs in a massive longitudinal study of aging. Dogs share our environment. They eat processed food. They breathe the same air. They develop many of the same diseases, including cancer, heart disease, kidney disease, and cognitive decline, and critically, they share our molecular pathways. The biological machinery that drives aging in dogs is fundamentally the same machinery that drives aging in humans. The crown jewel of the dog aging project is Triad, the test of rapamycin in aging dogs. This is the first rigorous test of a pharmacological anti-aging intervention with lifespan as a primary endpoint ever conducted outside a laboratory in any species. Healthy dogs over 7 years old weighing 44 or more pounds receive weekly low-dose rapamycin or a placebo for 3 years, followed by 2 years of monitoring. The study received a $7 million grant from the National Institute on Aging in 2025 and is expanding enrollment to 580 dogs. Earlier studies within the dog aging project had already shown that rapamycin improved cardiac function in dogs. If Triad demonstrates that rapamycin extends lifespan in companion dogs, animals who age in our homes and share our lives, the translational implications for human medicine would be profound. As Kate Creevy, the Chief Veterinary Officer of the Dog Aging Project, has said, all molecular pathways are the same. What works in dogs has a much higher probability of working in humans than what works in mice. The contrast between Parrish and the Dog Aging Project illuminates the full spectrum of the longevity movement. On one end, a CEO injecting herself with untested gene therapies in a foreign country, racing the clock with her own body as the experiment. On the other end, 580 golden retrievers and Labradors enrolled in a meticulously controlled trial that will take years to produce results, but will produce results that everyone can trust. Both approaches are driven by the same underlying belief that aging is not inevitable, that it can be slowed or reversed, that the tools to do so either exist already or are within reach. The disagreement is about method, about patience, about how much risk is acceptable when the prize is life itself. But whether the longevity revolution arrives through careful science or reckless self-experimentation, it raises a question that neither approach can answer on its own, a question that is not about biology at all. It is about justice. Because the therapies we have been discussing tonight, the gene therapies, the senolytics, the reprogramming treatments, the pig kidneys, the AI-designed drug cocktails, none of them are free. Most of them are extraordinarily expensive. And the gap between what the wealthy can access and what everyone else can afford is already vast. If longevity science succeeds, who gets to live? Chapter 9: The Longevity Divide. Before a single longevity drug reaches the market, before a single age reversal therapy becomes commercially available, before any of the science we have discussed tonight changes anything for the average person, there is already a gap, and it is enormous. In 2025, an analysis published by the National Council on Aging found that the poorest 10% of older American adults die, on average, 9 years earlier than the wealthiest 10%. 9 years. Not months, years. A full decade of life, separated by nothing more than the size of a bank account. Mortality rates among households earning below $60,000 per year are nearly double those of the wealthiest quintile. This is not a gap created by exotic gene therapies or experimental pig kidneys. This is a gap created by the basics: access to healthy food, access to preventive care, access to clean air and safe housing, access to the kind of stress-free environment that allows a body to maintain itself rather than break down under the weight of chronic cortisol and inflammation. Wealth buys all of these things. Poverty denies them. And the biological consequence is written in the mortality statistics with brutal clarity. Now imagine layering longevity science on top of this existing inequality. The treatments we have discussed cost money, significant money. Brian Johnson spends over $2 million per year on his Blueprint protocol. Telomerase gene therapy through BioViva reportedly costs $2.5 to $3.5 million per dose. High-end longevity clinics in Switzerland and the United Arab Emirates charge tens of thousands of dollars annually for comprehensive monitoring and experimental interventions. Whole genome sequencing, epigenetic age testing, VO2 max analysis, personalized supplement regimens. These are not covered by insurance. They are paid out of pocket by people who can afford them. The American Medical Association's Journal of Ethics dedicated its entire December 2025 issue to this problem. The title asked a deliberately provocative question: aging is bad for you. The issue did not debate whether aging causes suffering. Of course it does. The issue examined whether the rush to treat aging as a disease could deepen existing inequalities, undermine civic virtue, and create a world where the rich live fundamentally different lifespans than the poor. Mark Cohen, a researcher at the University of Massachusetts, Boston, wrote that we have come to accept an extraordinary level of income and resource inequality. The longevity divide, he argued, is simply the biological expression of an economic divide that already exists. The rich do not just live better, they live longer, and they have always lived longer. What changes with longevity science is the magnitude. Instead of a 9-year gap, we could be looking at a 30-year gap, or a 50-year gap, or a gap that becomes permanent, where the wealthy achieve something approaching indefinite lifespan, while the poor continue to die on the same schedule their grandparents did. The global picture is even starker. Within a single wealthy country, the life expectancy gap between richest and poorest is roughly 10 years. Between the richest and poorest nations on Earth, the gap is over 30 years. Norway has a life expectancy of 83. Chad has a life expectancy of 52. If advanced anti-aging therapies remain concentrated in wealthy nations, a pattern that has held for every previous medical innovation, from antibiotics to organ transplants, the disparity between rich and poor countries could expand from decades to generations. Michael Gervin, an anthropologist at the University of California, Santa Barbara, and the author of a comprehensive study on aging across human populations, has argued that the longevity field needs to stop treating aging as a niche concern for the wealthy. Gervin emphasizes the distinction between adding life to years versus adding years to life. Extending the lifespan of a billionaire from 90 to 150 while a dialysis patient in Alabama dies at 63 is not a victory for medicine. It is a failure of priorities. Marco De Maria, the editor of the journal Aging, wrote an editorial in 2025 that struck a similar note. He warned that the explosion of longevity clinics, many of which operate with minimal oversight and maximum marketing, risks reinforcing inequality and weakening the credibility of the science behind aging research. When longevity becomes a luxury brand rather than a public health initiative, the conversation shifts from "how do we help everyone age better" to "how do the rich escape aging entirely?" There are counter-arguments. Optimists point out that every transformative medical technology in history has started expensive and become cheap. Antibiotics were once exotic. Vaccines were once scarce. Genomic sequencing once cost $3 billion and now costs a few hundred. The pattern of technology is democratization. What begins as a luxury ends as a commodity. If rapamycin proves effective as a geroprotector, it is already a generic drug that costs pennies per pill. Metformin, the diabetes drug being tested as an anti-aging agent in the TAME trial, costs less than $1 a day. Dasatinib and quercetin, the first-generation senolytic cocktail, are available now for modest cost. The argument goes that the billionaires funding longevity research are not hoarding the science. They are accelerating it. The $3 billion Jeff Bezos poured into Alto's labs, the $1 billion flowing into retro biosciences. These investments are funding basic research that will eventually benefit everyone. The rich are the early adopters, the test cases, the ones who pay the premium that funds the development pipeline. Eventually, the treatments will come down the cost curve and reach the general population. Eventually, that word carries an enormous amount of weight. Because for the person on dialysis right now, the person who cannot afford preventive care right now, the person whose neighborhood does not have a grocery store with fresh vegetables right now, eventually is not a promise. It is a death sentence with a different delivery date. The World Economic Forum published a set of longevity principles in 2024, calling for a fundamental reimagination of the social contract around extended lifespans. They argued that societies need to design systems for social connection, purpose, and economic participation that extend across longer lives. But principles are not policies, and policies are not access. The honest truth is that no one knows how this plays out. The longevity divide could widen catastrophically, creating a world where biological age becomes the ultimate class marker. Or it could narrow as technologies mature and costs fall, creating a world where everyone benefits from the discoveries being made today. The outcome depends on choices that have not been made yet, by governments, by corporations, by the public, by us. But one thing is certain: the gap between rich and poor is already a death sentence measured in years. If longevity science widens that gap further, we will not have cured aging. We will have weaponized it. And yet, while the ethics remain unresolved, the science continues to advance. There is a drug that has extended lifespan in every organism it has ever been tested in, from yeast to worms to flies to mice. A drug discovered in one of the most remote and mysterious places on Earth. A drug that might be the closest thing we have to a proven geroprotector. And the largest study ever designed to test it outside a laboratory is already underway. Chapter 10: The Rapamycin Gamble. In the early 1970s, a Canadian expedition collected soil samples from Easter Island, a tiny volcanic speck in the southeastern Pacific Ocean, known to its inhabitants as Rapa Nui. The island is famous for its monumental stone statues, the moai, and for its extreme isolation. It is one of the most remote inhabited places on Earth. In those soil samples, researchers at a pharmaceutical laboratory in Montreal discovered a compound produced by the bacterium Streptomyces hygroscopicus. They named the compound rapamycin, after the island where it was found. Initially, it was studied as an antifungal agent. Then researchers discovered it had potent immunosuppressive properties, and it was developed as a drug to prevent organ rejection after transplant surgery. It is used in hospitals around the world for that purpose today. Is less than #0. 5# is greater than, but rapamycin had a secret, one that would not be fully understood for decades. Rapamycin inhibits a protein complex called mTOR, which stands for mechanistic target of rapamycin. mTOR is one of the most important regulators in cell biology. It is a master switch that controls cell growth, cell division, protein synthesis, and nutrient sensing. When nutrients are abundant, mTOR is active, telling cells to grow and divide. When nutrients are scarce, mTOR is suppressed, shifting the cell into a maintenance and repair mode. At low doses, rapamycin appears to mimic the effects of caloric restriction at the cellular level. It tells the cell that resources are limited and that the priority should be repair rather than growth. Autophagy, the cellular recycling program that clears out damaged components, is activated. Inflammation is reduced. Senescent cell accumulation slows. The cell shifts from a mode of aggressive growth to a mode of careful maintenance. And this shift, this rebalancing between growth and repair, has a remarkable effect on lifespan. Rapamycin is the most robust and reproducible lifespan extending drug ever tested in laboratory mice. It has extended lifespan in every organism it has been tested in: yeast, worms, fruit flies, mice. In the gold standard interventions testing program, rapamycin increased median lifespan in mice by 23% in males and 26% in females. These are not small effects. These are among the largest pharmacological lifespan extensions ever recorded. And the drug works even when started late in life. Mice that began receiving rapamycin at 20 months of age, roughly equivalent to 60 years in human terms, still showed significant lifespan extension. This is critical because it means the drug does not just slow aging if started early. It can reverse some of the accumulated damage even when administered to already old animals. Now, the question that hangs over the entire longevity field is whether rapamycin can do the same thing in humans. And the answer is being pursued right now through the most ambitious study of its kind ever designed. The Triad study, the test of rapamycin in aging dogs, is the first rigorous test of a pharmacological anti-aging intervention with lifespan as a primary endpoint ever conducted outside a laboratory in any species. The study enrolled healthy companion dogs over 7 years of age, weighing 44 or more pounds. The dogs receive low-dose weekly rapamycin, or a placebo, for 3 years, followed by 2 years of monitoring. 580 dogs will participate. Why dogs? Because dogs age in our homes. They share our environment, our air, our food sources, our stress levels. They develop the same diseases we do, including cancer, heart disease, kidney disease, and cognitive decline. And the molecular pathways that drive aging in dogs are fundamentally the same pathways that drive aging in humans. A result in dogs is far more translatable to humans than a result in laboratory mice housed in sterile conditions eating carefully controlled diets. Earlier studies within the Dog Aging Project had already produced encouraging signals. Rapamycin improved cardiac function in dogs. Echocardiographic measurements showed improvements in heart health that were consistent with the cardiac benefits observed in mouse studies. The question Triad is designed to answer is whether these health benefits translate into actual lifespan extension in a non-laboratory animal. If 580 dogs living normal lives in normal homes with normal owners live significantly longer because of a weekly rapamycin dose, it will be the strongest argument ever made for human trials of rapamycin as a geroprotector, not a cancer drug, not an immunosuppressant, a drug prescribed specifically to slow aging. The evidence from human studies, while limited, is provocative. A study found that 6 weeks of treatment with a rapamycin derivative called everolimus rejuvenated immune function in healthy elderly people, improving their response to influenza vaccination. This was a direct demonstration that mTOR inhibition could reverse at least one measurable aspect of immune aging in humans. The 2025 combination study pairing rapamycin with trametinib, which we discussed earlier, is generating intense interest precisely because it demonstrates the principle that rapamycin's already impressive effects can be amplified by combining it with drugs that target other arms of the same network. The future of rapamycin in anti-aging medicine may not be rapamycin alone, but rapamycin as the foundation of a multi-drug protocol. There are risks. At the immunosuppressive doses used in transplant patients, rapamycin has significant side effects. Mouth ulcers called stomatitis, metabolic changes including elevated blood sugar and cholesterol, increased susceptibility to infection. These effects are well documented and they are real. The entire bet is that at low, intermittent doses, rapamycin delivers the anti-aging benefits without the immunosuppressive costs, that the therapeutic window between geroprotection and immunosuppression is wide enough to walk through safely. Matt Keeberlein, the University of Washington researcher who co-founded the Dog Aging Project, has expressed cautious optimism. He considers rapamycin the most promising geroprotective intervention currently known, while also noting that no animal study has yet exceeded the lifespan extension achievable through simple caloric restriction. The bar is high. Rapamycin may clear it, but the evidence from large-scale studies in dogs and eventually humans will be the ultimate test. Brian Kennedy of the Buck Institute for Research on Aging has voiced similar caution, emphasizing that mouse results do not always translate. and that the history of anti-aging research is littered with interventions that looked spectacular in rodents and disappointed in people. The rapamycin gamble is real. The drug is already approved. It exists in every transplant pharmacy on the planet. The question is not whether it works in mice. The question is whether the right dose, the right schedule, the right combination can safely slow aging in people. And that question is being answered right now. In 580 living rooms across America, by dogs named Buddy and Bella and Max, whose owners love them and whose data will change the world. Rapamycin might slow aging. Senolytics might clear the damage. Gene therapy might reverse it. But even if all of that works, even if we solve every hallmark of aging, there is something deeper that the science has not touched. A question that humans have never had to face before. What happens to the world if people stop dying? Chapter 11. What happens to a world without death? Every pension system on Earth was designed with one assumption, that people would die. Social Security in the United States was created in 1935, when the average life expectancy was roughly 61 years. The retirement age was set at 65. The math was simple. Most people would pay into the system for decades and collect for a few years. The system worked because death was the balancing mechanism. People contributed more than they consumed because they did not live long enough to drain the fund. Today, life expectancy in the United States is roughly 77 years. In Japan, it is 84. In parts of Europe, it is over 80. Retirement systems designed for populations that died at 65 are now supporting populations that live to 85 and beyond. The strain is already showing. Social Security's trust fund is projected to be depleted within the next decade without structural reform. Pension systems across Europe are raising retirement ages, cutting benefits, or both. Now imagine what happens if radical life extension works. If people routinely live to 120 or 150 or beyond. A retirement portfolio designed to last 20 years would need to last 50 or more. Even modest inflation can devastate purchasing power over half a century. $1 today is worth roughly 30 cents in 50 years at 3% annual inflation. Your savings do not just have to last longer, they have to survive the erosion of time on a scale that no financial system was built to handle. The World Economic Forum has called for a fundamental reimagination of the social contract around longevity. They are right. Because the social contract we have was written for a species that dies on a predictable schedule. Remove that schedule and the contract breaks. But the economic disruption is only one dimension of a much larger question. What happens to population? If people stop dying at 70 or 80, do we face a crisis of overpopulation? The math is more complex than it first appears. Birth rates in the world's wealthiest nations are already collapsing. South Korea's fertility rate is the lowest ever recorded for any country in human history. Japan's population is shrinking. Much of Europe faces demographic decline. These countries do not have a population growth problem. They have a population collapse problem. Not enough young workers to support the growing number of elderly dependents. Radical life extension could paradoxically be the solution. If people at 70 or 80 are biologically 40 or 50, they do not need to retire. They can continue working, creating, contributing economically and socially. The dependency ratio, the ratio of non-working elderly to working adults, could actually improve. More productive years per person, less time spent in decline, less burden on healthcare systems designed to manage chronic degenerative disease. But this optimistic scenario depends on a critical assumption, that extended life means extended health. If longevity science simply extends the years of decline, adding decades to the period of frailty, disability, and dependence, then the economic and social costs would be devastating. 20 extra years of dialysis, 20 extra years of dementia care, 20 extra years of nursing homes. That is not a utopia, that is a nightmare. This is why the most thoughtful voices in the longevity field emphasize health span over lifespan. The goal is not to add years to life, but to add life to years. Michael Gervin of the University of California, Santa Barbara has argued that the anti-aging gold rush should focus on quality of life, not just quantity. If the result of all this research is that people live to 150 but spend the last 60 years in decline, we will have created a problem worse than the one we solved. And then, there is perhaps the most unsettling question of all. What happens to cultural and social progress in a world where people do not die? Every major transformation in human history has been driven in part by generational turnover. New ideas gain dominance not only because they are better, but because the people who held the old ideas eventually pass away. The civil rights movement succeeded not just through moral argument, but because the generation that enforced segregation aged out of power. The digital revolution accelerated not just through innovation, but because the generation that resisted it was replaced by one that embraced it. Power, wealth, and influence accumulate with age. In a world where the powerful never die, social mobility could freeze. A CEO who lives to 200 might hold their position for a century. A senator who never ages out of office could serve for generations. Generational wealth, already one of the most powerful drivers of inequality, would compound indefinitely. Instead of estates being distributed and redistributed across generations, fortunes would grow and concentrate in the hands of individuals who never relinquish them. Culture itself could stagnate. The fresh perspectives that come from new generations, the willingness to question assumptions and challenge orthodoxies, depend on the arrival of people who did not grow up inside the existing system. A society of 200-year-olds might be wiser in some ways, but it might also be ossified, rigid, resistant to change in ways that are difficult to predict but easy to fear. Democracy could calcify. Political movements thrive on energy, on outrage, on the impatience of youth confronting systems that no longer serve them. What happens when the systems are designed by people who have been in power for a century and show no signs of leaving? What happens when the old guard is not just metaphorically entrenched, but literally immortal? These are not hypothetical questions for a distant future. They are questions that need answers now, while the science is still developing, while there is still time to shape the policies and institutions that will govern a world of extended lifespans. Because by the time the technology arrives, it will be too late to build the frameworks. They need to be in place before the first person lives to 150. The science is racing forward, the society is standing still, and that gap between technological capability and social preparation may turn out to be the most dangerous gap of all. But while the philosophers debate and the economists calculate, the laboratories have not stopped. There are chemical cocktails being tested right now that can reverse the age of human cells in less than a week. Without gene therapy, without viral vectors, without any modification to the genome at all. Just chemicals applied to old cells, making them young. Chapter 12. The Chemical Fountain of Youth. In 2023, David Sinclair's laboratory at Harvard published a finding that shifted the conversation about aging intervention from science fiction to something uncomfortably close to reality. They identified 6 chemical cocktails, combinations of small molecules already known to science, that reversed the transcriptomic age of human cells in less than 1 week. No gene therapy, no viral vectors, no modification to the DNA. Just chemicals applied to old cells that made them behave like young cells again. The team used high-throughput cell-based assays, including a real-time measurement of how well cells maintain the separation between their nucleus and their cytoplasm, a function that degrades with age. They screened thousands of compounds and identified combinations that restored youthful gene expression patterns in senescent human fibroblasts. The treated cells were by every measurable standard indistinguishable from young cells. Their gene expression profiles matched, their functional characteristics matched. The chemical cocktails had achieved what previously required genetic reprogramming through the Yamanaka factors. Sinclair called this chemical epigenetic reprogramming of cellular health. The significance was enormous. Gene therapy is complex, expensive, and difficult to deliver systemically. Chemical cocktails are simple, potentially cheap, and can be taken as pills. If chemical reprogramming works in a living organism the way it works in a dish, it transforms anti-aging therapy from an exotic medical procedure into something that looks remarkably like taking your daily vitamins. But the chemical revolution in anti-aging extends far beyond Sinclair's cocktails. There are drugs already in widespread clinical use that may have significant anti-aging properties, and the most famous of them has been sitting in pharmacies for decades. Metformin is one of the oldest and most prescribed diabetes drugs in the world. It has been used since the 1950s. It is generic, it is cheap, it costs less than $1 a day. And observational studies have repeatedly found that diabetic patients taking metformin live longer than non-diabetic patients not taking any anti-aging drug at all. Diabetics on metformin are outliving healthy people. That finding alone should make you pause. The TAME trial, targeting aging with metformin, is the first clinical trial ever explicitly designed to test an anti-aging drug in humans. Led by Nir Barzilai at the Albert Einstein College of Medicine, TAME is enrolling thousands of older adults to determine whether metformin can delay the onset of age-related diseases, including cancer, cardiovascular disease, cognitive decline, and overall mortality. The trial is not testing whether metformin treats any single disease. It is testing whether metformin slows aging itself. If it succeeds, it will be the first time a regulatory body has recognized aging as a treatable condition. The implications for drug development, for insurance coverage, for the entire framework of how medicine approaches the human body would be transformative. Then, there are the GLP-1 receptor agonists. Semaglutide and liraglutide, the drugs behind the Ozempic and Wegovy phenomenon, were developed for diabetes and obesity. But research is revealing benefits that extend far beyond weight loss. These drugs show improvements in mitochondrial function, reductions in chronic inflammation, cardiovascular benefits that appear to be independent of their effects on weight. Some researchers believe they may be acting on fundamental aging pathways, not just metabolic ones. The explosion of interest in GLP-1 agonists may turn out to be the largest accidental anti-aging experiment in history, with millions of people taking drugs that have effects on aging biology that we are only beginning to understand. NAD+ precursors represent another avenue. Nicotinamide mononucleotide and nicotinamide riboside are supplements aimed at restoring levels of NAD+, a coenzyme critical for cellular energy production that declines significantly with age. The decline in NAD+ is linked to mitochondrial dysfunction, one of the 12 hallmarks of aging. Supplementation studies in mice have shown improvements in muscle function, cognitive function, and metabolic health. Human data is still emerging, but the supplementation market has exploded, with millions of people already taking NAD+ precursors in an attempt to address this specific hallmark of aging. The consistent finding across all of longevity research is that combinations outperform single interventions: rapamycin plus trametinib, dasatinib plus quercetin, multiple senolytics targeting different pathways, chemical cocktails addressing multiple hallmarks simultaneously. The biology of aging is not one problem, it is 12 interconnected problems, and the most effective approach is to attack as many of them as possible at the same time. This points toward a future of anti-aging medicine that looks less like a single breakthrough pill and more like a personalized, annually updated protocol. A software update for your biology. You walk into a clinic. Your blood is drawn. Your epigenetic age is measured. Your senescent cell burden is assessed. Your biomarker panel is analyzed by an AI system trained on the data of millions of patients. And you receive a customized prescription, rapamycin at this dose, a senolytic cocktail for this many cycles, a chemical reprogramming agent at this concentration, an NAD plus precursor at this level. Adjusted every year as your biology changes and as new compounds become available. This is not fantasy. Every component of this scenario either exists today or is in clinical trials. The epigenetic clocks exist, the biomarkers exist, the AI systems exist, the drugs exist. What does not yet exist is the integrated framework to combine them. But the framework is being built by companies like Retro Biosciences and Altos Labs, by academic labs at Harvard and the Mayo Clinic and the Buck Institute, by the AI systems that are accelerating every step of the process. After the philosophical weight of our last chapter, there is something grounding about returning to chemistry, to molecules, to things you could hold in a pill bottle. The breakthroughs in chemical reprogramming, the existing drugs that may already slow aging, the combination protocols being tested, these bring the conversation back from the abstract to the tangible, back from what if to what now. But there is one more conversation we need to have before we reach the end. A conversation that is not about science or money or logistics. A conversation about meaning. Because for as long as humans have existed, death has given life its structure, its urgency, its weight. And there are those who argue that removing death would not liberate us, it would hollow us out. Chapter 13. The Case Against Immortality. The German philosopher Martin Heidegger argued that death is not the end of life. It is the condition that makes life meaningful. He called it being toward death. The awareness that your time is finite is what compels you to use it, to create, to love fiercely, to take risks, to choose this rather than that, because you cannot do everything, because the clock is running, because the window is closing. Without a deadline, Heidegger suggested, there is no urgency. Without urgency, there is no authenticity. Without authenticity, there is no life worth living. This is the philosophical case against defeating death, and it is worth taking seriously, because the people making it are not fools. They are not afraid of progress. They are asking a question that the longevity optimists often dismiss too quickly. What if the limit is the point? Consider what you have done with your life so far, the choices you made, the risks you took, the relationships you prioritized. How many of those decisions were shaped by the knowledge that your time was finite? Would you have married when you did? If you had 500 years to find a partner, would you have started that project, written that book, said those words to the person you love, if you believed there would always be more time? There is a concept in psychology called the positivity effect. Research has shown that older adults, people who are aware that their remaining time is limited, tend to experience more positive emotions, form deeper relationships, and derive more satisfaction from daily life than younger adults. The awareness of mortality does not only cause suffering, it also produces clarity. It forces you to prioritize, to stop wasting time on things that do not matter, to pay attention to what does. Would a 500-year life be 5 times richer than a 100-year life, or 5 times more diluted? Would you treasure each day if you had 180,000 of them? Or would the infinite horizon make every individual moment feel weightless, interchangeable, expendable? Is less than has hone. 5 hash is greater than. There is an ecological argument as well. Earth is already groaning under the weight of 8 billion people living 70-year lifespans. We are consuming resources faster than they regenerate. We are warming the climate. We are driving species to extinction at a rate that matches the great mass extinctions of the geological past. Climate change is partly a consequence of too many humans consuming too much for too long. Even with birth rates falling in developed nations, extending lifespans to 150 or beyond in all populations, would put extraordinary pressure on food production, energy systems, housing, water supplies, and biodiversity. The planet does not have infinite capacity, and adding decades or centuries to the lives of its most resource-intensive inhabitants, namely us, without fundamentally changing how we live and consume, would be ecologically catastrophic. The counterargument is that longer-lived people would have more reason to care about the long-term health of the planet. If you are going to be alive in 200 years, you have a powerful personal incentive to prevent environmental collapse. Short lifespans might actually be part of the problem. People who know they will die in 50 years have less motivation to protect a future they will never see. Immortals, by contrast, would have to live in the world they create. It is an interesting argument, but it assumes a level of rationality and long-term thinking that human history does not strongly support. And then there is the argument about power. We discussed it briefly in the last chapter, but it deserves its own weight here. Power, wealth, and influence accumulate with time. The longer you live, the more you acquire. In a world where death is the great equalizer, every generation gets a reset. The powerful die. Their wealth is distributed, however imperfectly. Their positions open up. New voices enter. New ideas circulate. The social order refreshes itself, not perfectly, not quickly, but inevitably. Remove death, and you remove that reset. A billionaire who lives forever is not just wealthy, he is a permanent economic institution. A political leader who never ages out of office is not just powerful, she is an eternal dynasty of one. The concentration of power that already defines our era would intensify beyond anything human civilization has experienced. The American Medical Association's Journal of Ethics addressed this directly in its December 2025 issue. The authors argued that anti-aging ventures test our fundamental notions of wisdom, civic virtue, and what constitutes a good life. They questioned whether a society that solves aging would still value the qualities that death currently forces upon us: humility, gratitude, the willingness to make room for those who come after. Leon Kass, the philosopher who chaired the President's Council on Bioethics under George W. Bush, has argued most forcefully that mortality is not a curse, it is a gift. The limit gives life its shape. The knowledge that it will end gives every moment its weight. Defeat death, Kass argues, and you do not free humanity. You impoverish it. These arguments are powerful. They are ancient. They echo through Stoic philosophy, through Buddhist teachings on impermanence, through the poetry of every civilization that has ever grappled with the fact that we die. The case against immortality is the case for meaning through limitation, for beauty through transience, for the preciousness of time precisely because it runs out. But there is another way to look at all of this, and it is worth stating plainly. Every philosophical argument for the beauty of death was made by someone who had no choice. No one who argues that mortality is a gift has ever been offered the alternative. The philosophy of acceptance is the philosophy of the powerless. It is the story we tell ourselves when we cannot change the outcome. It is the fox saying the grapes were sour. For the first time in human history, there may be a choice, not a hypothetical, not a thought experiment, an actual choice, backed by science, funded by billions, and approaching clinical reality. And when that choice arrives, the philosophical arguments will be tested against something they have never faced before: the opportunity to choose differently. Maybe death has a purpose, maybe the limit is the point, or maybe that is just the story we told ourselves because we never had another option. Chapter 14: The Choice. So here we are, at the end of a long night. At the end of a journey through laboratories and clinics and philosophical arguments that most people will never encounter, and now we have to sit with what we have learned. Let us lay it out plainly. In 2023, scientists published the most comprehensive map of aging ever created. 12 hallmarks, 12 targetable mechanisms, not fate, not destiny, machinery. In 2024, a gene therapy using 3 Yamanaka factors extended the remaining lifespan of geriatric mice by 109%. Their epigenetic clocks reversed. Their frailty improved. They got younger. In February 2025, the LEV Foundation completed its first robust mouse rejuvenation study, demonstrating that combining multiple damage repair therapies produces additive lifespan extension. A qualified win for the entire strategy of attacking aging on multiple fronts simultaneously. In May 2025, researchers at the Max Planck Institute published that combining rapamycin and trametinib extends median lifespan in mice by up to 35%. In June 2025, Shift Bioscience revealed SB000, a single gene that can rejuvenate human cells without activating pluripotency pathways. In 2025, the FDA approved formal clinical trials for genetically edited pig kidneys from eGenesis. Tim Andrews lived 271 days with a pig kidney and threw a baseball at Fenway Park. Bill Stewart rode a bicycle for 2 hours with his. Life Biosciences received IND clearance in early 2026 to begin human trials of epigenetic reprogramming for optic neuropathies. Senolytic drugs have entered phase 2 clinical trials, showing personalized efficacy based on individual senescent cell burden. The Dog Aging Project is testing rapamycin in 580 companion dogs, the first large-scale lifespan trial of a geroprotector outside a laboratory. AI is compressing drug discovery timelines from 12 years to 18 months. This is not 2050. This is not some distant hypothetical future. This is now. These studies are running. These patients are alive. These drugs exist. The question is no longer whether aging can be slowed or reversed. The evidence from mice, from cells, from the first human cases says yes. The question is how fast the science translates from animals to people, and whether it translates in time for you. Aubrey de Grey's most famous provocation hangs in the air tonight. The first person to live to 1,000 is probably only about 10 years younger than the first person to live to 150. If longevity escape velocity arrives, the cascade is exponential. Each decade of extended life carries you into the next generation of breakthroughs. The question is not how old you will ultimately get. The question is whether you will survive long enough to reach the threshold, whether you will still be here when the first truly effective anti-aging therapies become available. And here is the part that makes this personal. Longevity is only about 7 to 30% heritable. That means the vast majority of how long and how well you live is determined not by the genes your parents gave you, but by choices you make every day. Sleep, exercise, nutrition, stress management, social connection, preventive care, engagement with emerging science. Peter Diamandis has said it more directly than anyone. Your job is to stay alive long enough to intercept the breakthroughs, not through reckless self-experimentation, not through million-dollar supplement regimens, through the basics, the boring, proven, unsexy basics that add years to your life and life to your years, while the laboratories work on the extraordinary. But tonight is not just about strategy. It is about something larger, something that has no data set and no clinical trial. For the entire history of our species, death has been the frame around the picture. It determined how we loved, how we worked, how we built, how we grieved, how we told stories, how we made meaning. Every religion, every philosophy, every poem, and every prayer was shaped by the knowledge that we would end. The pyramids were built because pharaohs wanted to outlast their bodies. The cathedrals were built because believers wanted to outlast their world. Every monument, every masterpiece, Every act of defiance against the darkness was an attempt to leave something behind because we knew we could not stay. And now the science is suggesting that maybe we can stay, or at least stay longer, maybe much longer. And that changes everything, not just medicine, not just economics, not just politics, everything. What it means to be human, what it means to love someone, what it means to have a life. If you had 1,000 years, what would you do with them? Would you be braver or more cautious? Would you take more risks or fewer? Would you love more deeply knowing you had centuries to share, or more carelessly knowing there was always more time? Would you create more, knowing the horizons were vast, or less, knowing there was no urgency? Is less than #0, 5 is greater than. Would you be more compassionate, having lived long enough to understand every perspective, or more rigid, having settled into patterns that centuries of habit had cemented? Nobody knows. Nobody has ever had to answer these questions with anything other than imagination. But the generation alive right now may be the first that has to answer them for real. There is a temptation to end a documentary like this with a definitive statement, with a prediction or a warning or an inspiring call to action that ties everything together in a neat bow. But the honest truth is that nobody knows how this story ends. The science might succeed and transform human civilization. The science might stall in the gap between mice and people, as so many promising therapies have before. The breakthroughs might arrive, but only for the wealthy, deepening the fractures that already divide us. Or the breakthroughs might arrive for everyone, lifting the entire species into a future we cannot yet imagine. What we know is this: the question is no longer theoretical, it is practical, it is funded, it is in clinical trials, and it is personal. Because somewhere in the data, somewhere in the survival curves and the epigenetic clocks and the combination therapies and the pig kidneys, there is a line between the last generation that had no choice about aging and the first generation that does. And you might be standing on that line right now. We might be the last generation to die of old age, we might not. But for the first time in the history of life on this planet, the question is not settled by biology. It is settled by what we choose to do next. What would you choose? If you enjoyed this nighttime journey into the science of aging, please like this video and subscribe to the channel. Your support makes these detailed explorations possible. Tell me in the comments, do you think we will reach longevity escape velocity in our lifetime? Would you take an anti-aging therapy if it were available to you? And what do you think would change about the world if people stopped dying of old age? These are not just questions for scientists. They are questions for all of us, because the future of aging is not being decided in a laboratory alone. It is being decided by every choice, every conversation, every voice that says, "This matters." Thank you for listening. I will see you in the next journey.